Now, to start with, there are several gateways for structures to pass into the gluteal region and the lower limb. If you look here, you have the greater sciatic foramen there, through which the piriformis muscle enters the gluteal region, and above the piriformis muscle, certain structures pass into the gluteal region from the pelvic cavity. You have the superior gluteal nerve and vessels there. Then again through the greater sciatic foramen below the piriformis muscle, you get the inferior gluteal nerve and vessels plus the sciatic nerve, posterior cutaneous nerve of the thigh, and there are other structures that just pass through it and then enter the perineum, like the nerve to obturator internus, pudendal nerve and internal pudendal vessels that enter the pudendal canal later. Then between the hip bone here, between the hip bone, the superior pubic ramus, that area, and the inguinal ligament, several structures pass. You have the iliopsoas muscle, the tendon, and then the femoral vessels. You have the femoral nerve, and then the lymphatics pass through that area through the femoral canal. So these are some of the gateways for structures to pass between the maybe the posterior abdominal wall and the lower limb, or the pelvic cavity and the lower limb. About superficial veins and nerves, I'm not going to discuss all the superficial veins and nerves. Some of them are not so important to discuss, but we will see some of them. Now, the first one, the great saphenous vein, or long saphenous vein, we call it either way. It starts from the dorsal venous arch here, from the dorsum of the foot, the medial aspect of the dorsal venous arch, then passes immediately in front of the medial malleolus here, which is a constant position for this vein. So there are clinical implications. We will discuss the clinical importance of having it in that constant position. Then it ascends on the medial aspect of the leg, passes 5 centimeters or hand's breadth behind the medial border of the patella. Then it curves forward slightly, and it lies on the anteromedial aspect of the thigh here in that area, and then passes through the saphenous opening in the fascia lata. Again, we will discuss that, and enters the femoral vein at the saphenofemoral junction here. Saphenofemoral junction. So that is the basically the summary of the course of the great saphenous vein. Then the important point, one important point is that the only branch of the femoral nerve entering the leg, which is a cutaneous branch, the saphenous nerve, accompanies the great saphenous vein there. It actually lies in front of the great saphenous vein. Again, we will discuss that when we discuss the clinical side of this. Then the small saphenous vein, or the short saphenous vein, this one, it lies on it actually starts from the lateral side of the dorsal venous arch, passes behind the lateral malleolus, and lies on the posterior aspect of the leg, and pierces deep fascia at the popliteal fossa and enters the popliteal vein. A cutaneous nerve, which is the sural nerve, accompanies the small saphenous vein. Then when it comes to valves, there are valves in the veins of the upper limb and lower limb both, but there are more valves in the veins of the lower limb. And if you compare the deep veins and superficial veins, there are more valves in the deep veins of the lower limb than the superficial veins. So remember that point. Okay, so this I actually mentioned, the saphenous nerve accompanying the great saphenous vein and the sural nerve accompanying the small saphenous vein. Veins of the foot. Like in the hand, there are digital veins related to the toes, and the digital veins form metatarsal veins, and these metatarsal veins, they open into the medial and lateral plantar veins. Medial and lateral plantar veins. Actually, the lateral plantar vein like the lateral plantar artery, forms the lateral plantar venous arch actually. Whatever, these the plantar veins, digital veins open into plantar veins, and the plantar veins form enter into medial and lateral plantar. Digital veins enter into metatarsal veins, and the metatarsal veins enter into medial and lateral plantar veins. And before they enter the medial and lateral plantar veins, the metatarsal veins are connected up, or they drain into the dorsal venous arch, which is on the other side, on the dorsum. Here we are looking at the sole. They open into the dorsal venous arch through certain perforating veins. So when you walk, when there's pressure applied onto the sole of the foot, blood will drain into the dorsal venous arch through these perforating veins. So that's one point. Then the second point is these medial and lateral plantar veins. I'm referring to these medial and lateral plantar veins. As you can see here, they drain into the posterior tibial vein. They drain into the posterior tibial vein. And again, before they drain into the posterior tibial vein here, they have connections with on the medial side, the medial plantar vein is connected to the short saphenous vein, and the lateral plantar vein is connected to the the other way. Medial plantar vein opens into the long saphenous vein, and the lateral plantar vein opens into the short saphenous vein. There are connections between the two. Okay, so these are the connections between the short saphenous vein and the lateral plantar vein, and these are the connections between the long saphenous vein and the medial plantar vein. So the point here is that veins of the foot, especially the sole of the foot, they drain into both the superficial and deep systems of veins. We will discuss further about the superficial and deep venous systems later. Now about the nerves, again, all cutaneous nerves are not important to remember, but some of them may be important to remember. The first one, the lateral cutaneous nerve of the thigh, or the lateral femoral cutaneous nerve. And either you use the term lateral cutaneous nerve of the thigh, or lateral femoral cutaneous nerve. Then you don't use the term thigh if you use femoral. Okay, so both names are used frequently. Now this nerve, that it can get compressed under the inguinal ligament here, and then it can give rise to a condition called Meralgia paresthetica. You get pain, numbness, and paresthesia of the lateral aspect of the thigh, which is also called Bernard-Roth syndrome. So that is one point that you need to remember. And then the saphenous nerve, we mentioned it in the previous slides also. It accompanies the great saphenous vein, and it is important to know about it during venous cut down here, because if you damage the nerve, the patient will have numbness over the medial aspect of the foot here, there, okay, leg, and the lower part of the leg and the medial aspect of the foot. Then the superficial peroneal nerve. Superficial peroneal nerve, it's the nerve of the lateral compartment of the leg. The motor part of the superficial peroneal nerve, it supplies the peroneus longus and brevis muscles in the lateral compartment, and the cutaneous component enters the subcutaneous tissue in the lower part of the leg, supplies the anterior aspect of the lower part of the leg and the dorsum of the foot here. Then the other one is the deep peroneal nerve. Deep peroneal nerve here, it is the nerve of the anterior compartment of the leg, supplies the muscles in the anterior compartment, and the very small cutaneous component, sensory component left. It after supplying not only the anterior compartment, even the muscles in the dorsum of the foot. It supplies both anterior compartment here and the muscles in the dorsum of the foot. Then the cutaneous component supplies the first web. Okay. Then the posterior cutaneous nerve of the thigh, of course, it is the nerve that emerges from emerges below the piriformis muscle through the greater sciatic foramen together with the sciatic nerve. So the job of the posterior cutaneous nerve of the thigh is taken up by the sural nerve in the leg. Okay, so posterior cutaneous nerve of the thigh ends somewhere here, So that is the point that I want to raise. Then the sural nerve. So the point I raised, the job of the posterior cutaneous nerve of the thigh is taken up by the sural nerve, and this in peripheral nerve diseases, when you have to biopsy a nerve, sometimes, very rarely, you might have to do that. So this is the nerve that is chosen, sural nerve, for nerve biopsies. Okay, then the medial calcaneal nerve, branch of the tibial nerve. The important thing is it supplies the heel of the foot. Medial calcaneal nerve. Then this femoral branch of the genitofemoral nerve. Femoral branch of the genitofemoral nerve. The genitofemoral nerve is actually a branch from the lumbar plexus. We will see it again somewhere in another slide. Genitofemoral nerve is a branch of the lumbar plexus, and it lies in the inguinal canal together with the ilioinguinal nerve. And the femoral part of the genitofemoral nerve actually supplies the skin over the anterior aspect of the thigh, just below the inguinal ligament. And this area happens to be the area we use for femoral vein catheterization. So when we give local anesthesia, so we are actually blocking the femoral branches of the genitofemoral nerve. When we do that procedure, we will again revisit that procedure. Then the ilioinguinal nerve, the cutaneous supply to the thigh, is immediately medial to the genitofemoral nerve area. Again, when you do saphenous venous cut down at the saphenofemoral junction, sometimes you have to do it. Then the nerve that you have to block is the ilioinguinal nerve. Even though you don't know the name, you block it with local anesthetic agents. Okay, so it doesn't matter much. Then, as a summary, how the structures are related to the malleoli, subcutaneous structures, not all structures. Now, if you take the medial malleolus first, anterior to the medial malleolus lies the saphenous nerve and the great saphenous vein. Then posterior to the medial malleolus lies the posterior arch vein. We will discuss that later, posterior arch vein. Then when it comes to the lateral malleolus, anterior to the lateral malleolus lies the branches of the superficial peroneal nerve, and posterior to it lies the small saphenous vein and the sural nerve. Small saphenous vein and the sural nerve. So this is a diagrammatic representation of that, the saphenous nerve and the great saphenous vein in relation to the medial malleolus, and the sural nerve, and I have drawn it, the small saphenous vein in relation to the medial, the lateral malleolus. Then great saphenous vein has many tributaries, but some of them are relevant to mention here. Now, immediately before it enters the femoral vein, the saphenofemoral junction, there are 4 tributaries. You have branches from the femoral artery with the same names. The first few branches from the femoral artery with the same names. For that reason also you can remember them. And the superficial circumflex iliac, which is towards the lateral side. Then superficial epigastric, which drains the lower part of the anterior abdominal wall below the umbilicus. Then the superficial and deep external pudendal veins. You have other, other even larger tributaries like the anterior, the accessory vein. Then another important tributary to the great saphenous vein, which is clinically important, is the posterior arch vein. Posterior arch vein that lies immediately posterior to the medial malleolus, when the great saphenous vein lies immediately anterior to the medial malleolus. Now there are several perforating veins connecting up the deep venous system with the posterior arch vein. So that is the reason why it becomes clinically important. The posterior arch vein drains into the great saphenous vein below the knee joint area. Then like in the upper limb, in the lower limb also, deep veins, they follow arteries. Now the arteries of the lower limb, if you summarize the arteries of the lower limb, you have the femoral artery starting from the femoral triangle area below the inguinal ligament. Then at the adductor hiatus, the opening in the adductor magnus muscle, the femoral artery is called popliteal artery. The popliteal artery extends from the adductor hiatus to the soleal arch somewhere here, where it divides into the anterior and posterior tibial arteries. Then as a branch from the posterior tibial artery, the peroneal artery is given off. Now this same pattern is there when it comes to the deep veins. Deep veins follow arteries like vena comittantus. Okay, so then you have a posterior tibial vein and anterior tibial vein connecting up and forming the popliteal vein, which continues through the adductor hiatus as the femoral vein. The peroneal vein actually opens into the posterior tibial vein, just like the arterial circulation. So these are paired veins because they are vena comittantus. If you add the superficial venous system on top of this deep venous system, this is how you see it. You have the dorsal venous arch here, and from the medial aspect you get the great saphenous vein, and from the lateral aspect you get the small saphenous vein. And the small saphenous vein opens into the popliteal vein here. Then the great saphenous vein opens into the femoral vein at the saphenofemoral junction. Posterior arch vein drains into the great saphenous vein. This is what we discussed. So if I add perforating veins onto this, the perforators, this is how you see it. Now there can be a lot of variations, but so this is something that we can work on. There is a perforator in the lower part of the adductor canal, which connects the femoral vein to the great saphenous vein, which is called the adductor canal perforator. This one. Then there is a below knee perforator, which connects the posterior tibial vein either to the great saphenous vein or sometimes to the posterior arch vein, because they are very close there. Okay. Then lower down, there can be a lateral perforator which connects the small saphenous vein to the peroneal vein. And if you locate it, the vertical distance, it is roughly at the junction between the middle and the lower third of the leg. Then on the medial side, there are three perforators: upper medial perforator, middle medial perforator, and lower medial perforator. Upper medial perforator is about the same level as the lateral perforator, the junction between the middle and the lower third of the leg, and that connects the posterior tibial vein to the posterior arch vein. Then the other two perforators are also they are connecting the posterior arch vein to the posterior tibial vein, and they lie. The middle one lies immediately above, and the lower one lies immediately below the medial malleolus. So you don't have to remember the position of all these, but have a rough idea about how many the number of perforators you get. Can be many variations. So this is from one textbook. I got this pattern. Then the other point that you all know is that the deep veins, since there are a lot of valves in the deep veins, and most of the deep veins, they lie inside the muscles like the soleus muscle, and when the muscles contract, they squeeze the deep veins, blood is pushed towards the heart. When the muscles relax, the valves inside the deep veins prevent blood coming backwards, returning from the heart. But at the same time, when the muscles relax, the valves in the perforating veins, which are directed towards the deep veins, they open up, and the blood from the superficial veins enter the deep veins. And again, when the muscles contract, these valves close and these valves open. So always blood is sucked from the superficial veins to deep veins and pumped towards the heart when the muscles contract. It is called muscle pump. It is called venous pump sometimes, and to be more specific, sometimes it is called soleal pump, because mainly the soleus muscle is involved in this process. And this is possible because the deep veins, they lie deep to deep fascia, so the pressure inside the deep fascia increases when the muscles contract. So the superficial veins lie superficial to the superficial fascia, which is a basic fact that you all know. So this is a description about the position of the perforating veins and the superficial and deep veins connected by these perforating veins. I will not read this slide. You can go through it later since you have the PowerPoint presentation. Then this some of the clinical points that I wanted to discuss. Femoral vein catheterization. You can, if you want, you can read the steps and learn later on. But to summarize it, as we said before, for femoral vein catheterization, you have to give local anesthetic agent and block the femoral branch of the genitofemoral nerve in that area. And the other important point is you have to find the mid-inguinal point. Mid-inguinal point is the midpoint between the anterior superior iliac spine and the symphysis pubis. Anterior superior iliac spine and the symphysis pubis, somewhere here, which is medial to the pubic tubercle. So mid-inguinal point is that there, if you feel for pulse, you can get the pulse of the femoral artery at the mid-inguinal point. So your femoral vein lies immediately medial to that pulse. That's how you get at the femoral vein, and the point to insert the catheter is about 2 finger breadths, below the inguinal ligament at that point. 2 finger breadths below the inguinal ligament, you enter the catheter into the femoral vein. Then saphenous vein cut down at the ankle. You may be more familiar with these things than myself. Now for whatever the reason you want to cut down the saphenous vein, the great saphenous vein at the ankle, which is on the medial side in front of the medial malleolus. When you put this, when you give local anesthetic agent to that area and block the saphenous nerve, you put an incision and you can identify the saphenous nerve lying immediately in front of the great saphenous vein, and you have to preserve the saphenous nerve. If you damage the saphenous nerve, the patient will later complain numbness of the medial aspect of the foot. So that is the point that I wanted to raise. Then if you fail the saphenous vein cut down at the ankle, you can actually go for saphenous vein cut down at the groin. Whether you have to fail the previous one or not, I'm not very sure about. But anyway, you can do saphenous vein cut down at the groin at the saphenofemoral junction. Now, that is slightly medial to the point at which you do the femoral vein catheterization. It's a medial point. So here, actually, the nerve branches that are blocked are the ilioinguinal nerve branches, which is medial to the genitofemoral branches. And again, the incision here is taken from a different point. It's not from the inguinal ligament you take from the pubic tubercle. You take 2 finger breadths, again 2 finger breadths, below and lateral to the pubic tubercle in this case. Okay, so that is the point where the great saphenous vein enters the femoral vein. Okay, can you try this? I mean, these are not very standard high-level MCQs, but just just to recall what you just learned, you just try it. I will show you the answers after you try it. Okay, so these are the answers. Adductor canal perforator connects the great saphenous vein to femoral vein, true. Below knee perforator is connected to the anterior tibial vein. No, it's either the posterior tibial vein either to the yes, it's to the posterior tibial vein. Then lateral perforator connects small saphenous vein to anterior. It's the peroneal vein, not small saphenous. Medial perforators connect posterior arch vein to posterior tibial vein. Yes, that's true. Upper medial perforator lies in the middle of the leg. Noise the junction between the middle and the lower third roughly. Okay. Then few things about fascia lata. It's the deep fascia of the thigh. It's a fairly thick fascia. Its arrangement is like a stocking. And one important point before we discuss the attachments of fascia lata, it is attached to the inguinal ligament anyway. Inguinal ligament and the anterior superior iliac spine and the pubic tubercle, therefore, either side. Now, the point that I want to raise here at the beginning is that the superficial fascia of the abdomen, has two layers. I'll show you. Superficial fascia of the abdomen has a fatty layer, which is called the campus fascia, and a membranous layer, which is shown in green in this picture, which is called Scarpa's fascia. Now, this membranous layer, which is a tough layer compared to the superficial layer, this membranous layer is attached to fascia lata here, which is shown with these broken lines, about finger's breadth below the inguinal ligament. Membranous layer of superficial fascia of the abdomen is attached to the fascia lata. And when there is collection of fluid under the membranous layer, like in rupture of the penile urethra, you get bleeding into that space, superficial perineal pouch. You get fluid entering the anterior abdominal wall below this layer, membranous layer. So the fluid will lie between the membranous layer and the muscles and the aponeurosis of the anterior abdominal wall, and such fluid will not enter the thigh. Because of this attachment. Okay, so it's sealed off there. That is the point that I wanted to raise. Okay. Then about the attachments, other attachments of fascia lata, as I said before, it is attached to the inguinal ligament, and therefore the anterior superior iliac spine, and the attachment continues on the iliac crest, and it is the outer lip or the external lip of the iliac crest, because inside the attachment, deep to the attachment of fascia lata, you get the anterior abdominal wall muscles attached to the iliac crest. Then at the back behind, the fascia lata is attached to the posterior superior iliac spine, and the sacrum, coccyx, sacrotuberous ligament, and the ischial tuberosity here, and it splits to enclose two muscles. One, the tensor fasciae latae muscle here, a small muscle, and the gluteus maximus muscle here, a large one. Okay, so it splits to enclose these two muscles. Then the attachment continues over the ischiopubic ramus, and again coming back to the anterior side, from the ischiopubic ramus to the body of the pubis, then along the pectineal line here. So this is the point where the two leaves or the two layers of the fascia lata overlaps. The two layers, it started from here and ended here. If someone asks you to describe or explain the attachment of the fascia lata, you better start from one end of this leaf. Okay, so if you ask me, I will start from the pubic tubercle or the inguinal ligament and end at the pectineal line. Okay, if you start from somewhere here, then it's difficult to continue it, because you are left with one half here. Okay, so always start from one end and continue and end in the other end. Okay, now because of this overlap, a gap is created between the two layers, which is the saphenous opening, actually, through which the great saphenous vein enters, goes deep and enters the femoral vein. Then laterally, the fascia lata has got thickened, and it forms what is called iliotibial tract, which is also important. We will come back to iliotibial tract in a moment. Now, if you look at the arrangement of the two layers of fascia lata again, now you can identify this is the hip bone. Now this is the pectineal line. The black dotted line is the pectineal line. This is how the pectineus muscle is attached. Now pectineus muscle is found in the anterior aspect of the thigh. Now this is how the pectineus muscle is attached, and this is how the inner layer of fascia lata is attached. This is how the inner layer of fascia lata is attached, which is actually attached to the pectineal line, which we just described. Then this is the femoral sheath. This is the femoral sheath. Now the inner layer of fascia lata is superficial to the pectineus muscle. Then superficial to the inner layer of fascia lata lies the femoral sheath containing the femoral artery, vein, and the femoral canal. Now, superficial to that femoral sheath lies the outer layer of fascia lata. So, if you want to reach the femoral sheath, actually you have to dissect this and remove it. Then only you will reach the femoral sheath. Then if you want to see the other layer, the inner layer of fascia lata, actually you have to either remove or raise the structures in the femoral sheath with the femoral sheath. And when you reach the pectineus muscle, actually what you do is you remove the other layer, the inner layer of fascia lata as well. Otherwise, you can't see the pectineus muscle. So by the time you see the pectineus muscle in a dissection, actually you have removed both layers of fascia lata. Then the fascia lata, we discussed only the proximal attachments. Distally, at the knee, it is attached to all exposed bony points, like the patella, head of the fibula, then femoral and tibial condyles, both lateral and medial. To all these structures, the fascia lata is attached. Then few points about the iliotibial tract, Mason's band or something, you call it another name. Then the first thing is that it splits to enclose the tensor fasciae latae muscle here, and it is attached to the iliac tubercle there, and the tensor fasciae latae itself and the gluteus maximus, they are inserted to the iliotibial tract. So when the two muscles contract, tension in the iliotibial tract increases. And the iliotibial tract distally, it is attached to the lateral condyle of tibia here. Lateral condyle of tibia here, there is a tubercle called Gerdy's tubercle. So it is attached to the Gerdy's tubercle of the lateral condyle of tibia. And it at the hip joint, the iliotibial tract helps to extend, abduct, and laterally rotate the hip joint, and it stabilizes the knee joint laterally because it passes lateral to the knee joint, and helps to maintain the knee in hyperextension. And when the knee is hyperextended, the iliotibial tract is tensed. It's tensed, and it helps to keep, because the moment you hyperextend, the center of gravity passes behind the attachment of the iliotibial tract. So therefore, not behind, sorry, passes in front. Okay, when you hyperextend of the knee, the center of gravity passes in front of the attachment, distal attachment of the iliotibial tract, and it keeps the knee in that hyperextended position. Because that position is the locked position of the knee joint actually. In that position, actually the quadriceps muscles can relax. Okay, so you frequently do this when you are standing for a long time. Actually, you tend to hyperextend one knee joint while the other one is slightly flexed, and you bear the weight on the hyperextended knee joint. You can practice that. Okay, and the other point is the lateral intermuscular septum. Lateral intermuscular septum is attached to the deep surface of the iliotibial tract. We have discussed about this intermuscular septum when we discussed the upper limb. Now, if this is your bone, if this is your deep fascia, usually these thigh, leg, arm, they are divided into muscular compartments by intermuscular septa. So the intermuscular septa actually connect the periosteum of the bone to the deep fascia. So that is the general rule. Now here in the thigh, the laterally the fascia lata, which is the deep fascia, is thickened and the iliotibial tract is formed. So the lateral intermuscular septum is actually attached to the iliotibial tract, the thickening of the fascia lata. Okay, so that is what is mentioned there. Then few further points about the locking and unlocking of the knee joint. Locking and unlocking of the knee joint. Now what happens is during hyperextension, because of unavailability of articular surface on the at the femur tends to medially rotate on the tibia. Femur tends to medially rotate on the tibia, and the ligaments of the knee joint, the medial ligament, lateral ligament, oblique popliteal ligament, patellar ligament, all these ligaments, their directions are such that when the femur rotates medially on the tibia, all the ligaments get taut, they get tightened up, and as I said before, the center of gravity passes in front of the knee joint, iliotibial tract gets tensed, and the knee joint is said to be in the locked position. Okay, once it is locked, then you cannot flex it before unlocking. Unlocking of the knee joint is done by the popliteus muscle. Unlocking is done by the popliteus muscle, which is attached to the lateral condyle of the tibia here. Now this is the lateral side, lateral condyle of the tibia, and when the muscle contracts, it laterally rotates the femur on the tibia and unlocks the knee joint. From that position, you can flex the knee joint again. Okay, so for that reason, popliteus is also an important muscle. It is a deep muscle in the posterior compartment of the leg. We will discuss that when we discuss the leg. Okay, then compartments of the thigh. If you take the right thigh here, compartments. So as I said before, you can see the lateral intermuscular septum and the medial intermuscular septum. Only two defined intermuscular septa in the thigh, even though there are three compartments. Okay, so there is no defined intermuscular septum between the adductor compartment or the medial compartment and the posterior compartment. Now the lateral intermuscular septum is attached to the iliotibial tract here, as I said before. So that's one point. Then the medial intermuscular septum will be somewhere here like this. Okay, so this is the lateral intermuscular septum. So the knee is divided, the thigh is divided into three compartments: the anterior compartment, then the medial compartment or the adductor compartment. So this is also called extensor compartment. This is also called adductor compartment, and you have the posterior compartment or the flexor compartment. Okay, flexor compartment. So these are the muscles in these compartments. You have the quadriceps muscles consist of rectus femoris, vastus medialis, intermedius, and vastus lateralis. So that makes the quadriceps muscles. Then other than that, you have the sartorius muscle here. You have the sartorius muscle here. Then if you go up, if this is your the beginning of the thigh and this is the inguinal ligament there, you get the iliacus and the psoas muscles entering the thigh from the iliac fossa and the posterior abdominal wall. So they also actually contribute to the anterior compartment. You can add them, even though you don't see them in a cross section of the thigh here, horizontal section. Then there is another small muscle here, the pectineus muscle. You can include it as an anterior compartment muscle. There are confusions, I'll get back to it later. Then the adductor compartment, you have the gracilis muscle, then the adductor longus, brevis, and adductor magnus muscles. And again, other than these muscles, you can add another medially placed muscle here, obturator externus muscle, which is supplied by the same nerve that supplies the adductor muscles. So then the posterior compartment or the flexor compartment, you have the biceps femoris, semitendinosus and semimembranosus muscles, and part of the adductor magnus, which is called the hamstring part of the adductor magnus. So we'll get back to it. So these are the muscles. These are the the muscles that I have listed under each of these compartments. Now the point about the pectineus, iliopsoas, of course, you can add it, no problem. Pectineus is that some authors of textbooks, they add pectineus under anterior compartment, and some add it under medial compartment, because the pectineus is most of the time it's supplied by the femoral nerve. Okay, so that is the nerve of the anterior compartment. All these muscles are supplied by the femoral nerve. Most of the time pectineus is also supplied by the femoral nerve, but sometimes it is supplied by the obturator nerve. Pectineus can be supplied by the obturator nerve. For that reason, people label it under adductor compartment as well. It doesn't matter. Then the obturator externus, of course, obturator externus, it is supplied by the posterior division of the obturator nerve. So it's fair enough to include it under the adductor compartment. Then when it comes to the muscles of the posterior compartment, other than the biceps femoris, semimembranosus and semitendinosus muscles, you have to add the hamstring part of the adductor magnus. So that is the posterior part of the adductor magnus. And okay, so these are the muscles of the anterior compartment. You will see these things in specimens when you have the practical, maybe in December. Now, in the anterior compartment, you see the muscles. You have this one, the sartorius muscle, iliacus muscle, and the psoas underneath here, and you have the pectineus muscle. Then you have the quadriceps here. Okay. Posterior compartment, there is no place for me. Okay, I have to move around. The posterior compartment, all the muscles of the posterior compartment take origin from the ischial tuberosity. Ischial tuberosity. So this is the long head of this is the long head of biceps. Okay, then semimembranosus and semitendinosus muscles here. Okay, and the hamstring part of the adductor magnus here. Hamstring part of the adductor magnus. They are all in the posterior compartment. Then the sciatic nerve supplies all these hamstring muscles, and it is the sciatic nerve has its two components, the tibial component and the peroneal component. It is the tibial component of the sciatic nerve that supplies these muscles. Tibial component of the sciatic nerve. Okay, structures attached to the ischial tuberosity. So these are the answers. Okay, fascia lata is attached to it, correct? Biceps femoris, it's not the short head. Short head is attached to the shaft of the femur. It is the long head. It is the long head that is attached to the ischial tuberosity. The sacrotuberous ligament, of course. Then the semitendinosus and the adductor magnus, not the whole one, but the hamstring part of the adductor magnus is attached to it. Then motor nerve territories, we have partly discussed it. The anterior compartment, as we said before, is supplied by the femoral nerve, and the medial compartment, the adductor compartment, is supplied by the obturator nerve, and the posterior compartment is supplied by the tibial component of the sciatic nerve. So these are the three important nerves that supply the muscles of the thigh. Then the obturator nerve that supplies the adductor compartment, it has two divisions, the anterior division and the posterior division, and this division takes place in the obturator canal, high up. And then the two divisions come on either side of the adductor, the brevis muscle, the anterior division in front of it, posterior division behind it. And the hamstring part of the adductor magnus, as you can see here, is supplied by the tibial component of the sciatic nerve. Okay, so this part of the adductor magnus, as we said before. Okay, then a few points about the obturator nerve. Now that we discussed about it, it is a branch from lumbar plexus, and the lumbar segments carried in the obturator nerve are L2, L3 and L4. Now the important point to remember is that these are the same segments that are carried in the femoral nerve as well. L2, L3 and L4, they go in the femoral nerve, and both the obturator nerve and the femoral nerve are formed by the anterior primary rami of L2, 3 and 4. The anterior primary rami divide into anterior divisions and posterior divisions. From the posterior divisions, you get the femoral nerve. From the anterior divisions, you get the obturator nerve. Okay, from the anterior divisions, you get the obturator nerve. This one and this one. Okay, femoral and obturator nerves. So for that reason, it's important to remember. It's easy to remember, of course. So this is the point that I mentioned in the obturator canal. As you can see here, in the obturator canal, the obturator nerve divides into its anterior and posterior divisions. The posterior division, this one, passes through this is obturator internus, which is on the inner aspect of the pelvic wall, and this is the obturator membrane, of course, and this is obturator externus muscle. The posterior division passes through the obturator externus muscle, as you can see here, before it enters the thigh and lie between the adductor brevis and the adductor magnus muscles, supplying the adductor magnus muscle in that place. On the other hand, anterior division, this one, anterior division can supply the pectineus. I said that before, it can be supplied by the obturator nerve. Then it supplies the adductor longus and adductor brevis muscles. So if someone says that the adductor brevis lies between the two divisions of the obturator nerve, it's correct. Then the important point about okay, so this is about the anterior division. Okay, it supplies the hip joint as well here, and adductor longus, adductor brevis, and also the gracilis, and sometimes pectineus, and the skin on the medial aspect of the thigh. Now when it comes to posterior division, that is this one, posterior division, it supplies the adductor magnus, and it's a long division. Even though it's slender than the anterior one, it's long, and it enters the adductor, the lower end of the adductor canal, and passes through the adductor hiatus with the femoral vessels, and it supplies the knee joint. Okay, so that is the point. The important point is that the obturator nerve, the posterior division, supplies the knee joint. So there are different opinions about its presence in the adductor canal, but we will take it as present in the distal end of the adductor canal. Okay. So the femoral nerve is the same issue, same thing. 2, 3, 4 segments, posterior divisions in this case, same segments as the obturator nerve, and with the nerve of the anterior, the extensor compartment, and the two branches, the nerve to vastus medialis and the saphenous nerve, they enter the adductor canal. One is a motor nerve, this one, and the other one is the sensory nerve. Okay, so we discussed about the saphenous nerve at several occasions. Okay, so even though the femoral nerve is a large nerve, all its branches they supply the large muscles in the thigh, anterior compartment, and that is the end of the nerve, except for the saphenous nerve, which enters the leg. A few points about the femoral sheath. I think I will make it less. Few points about the femoral sheath. It is formed by the transversalis fascia from the anterior abdominal wall and iliacus fascia from the iliac fossa. So these fascial layers, they continue when the femoral vessels enter the thigh under the inguinal ligament. Transversalis fascia and iliacus fascia get dragged into the proximal end of the thigh, few finger breadths below the inguinal ligament, forming what is called femoral sheath. It is like axillary sheath in the upper limb. Axillary sheath formed by the prolongation of the prevertebral fascia, if you remember it correctly. The transversalis fascia and iliacus fascia prolongs into the thigh and forms the femoral sheath. Now, if you look at the femoral sheath, if it is something like this, there are two septa in the femoral sheath, dividing it into three compartments. This is lateral, this is medial, Femoral nerve lies lateral to the femoral sheath, which is an important point. Okay, it's not within the femoral sheath. Remember that point. The upper end of the femoral canal, this area is called the femoral ring, which is covered by femoral septum formed by extraperitoneal tissues. This area, femoral sheath. So it's femoral canal and is the femoral ring here. The femoral ring here, and is covered by the femoral septum, thickening of extraperitoneal tissues in that area. So when things herniate through that, they actually push the femoral septum in front of them. Okay, and if you look at the boundaries of the femoral ring, these are the boundaries of the femoral ring. You can read it. So the anteriorly you get the inguinal ligament. Posteriorly you get the pectineal ligament, which is attached to the pectineal line there. Then laterally you get the femoral vein and the medial septum of the femoral sheath. Then medially you get the sharp free edge, the cruciatic base or the free edge of the lacunar ligament. So this is the lacunar ligament, okay, which is attached to the inguinal ligament here. Okay, so here you get the femoral ring. Okay, so femoral septum covers the femoral ring here, which is thickening of extraperitoneal tissues. Okay, so when you happen to get femoral hernias, actually the contents of the femoral hernia can get actually compressed by this the sharp edge, crescentic edge or the base of the lacunar ligament. And the femoral hernias, I'm not going to talk about femoral hernias. It's a differential diagnosis for inguinal hernias. The point to remember about femoral hernias is that they lie below and lateral to the pubic tubercle, whereas the inguinal hernias lie above and medial to the pubic tubercle. So that is the important point. And the other thing is when the hernial sac lies, you get the fascia lata attached to that area. Hernial sac lies deep to fascia lata, which is a thick fascia. Okay, so here it lies deep to fascia lata, but if it gets enlarged, actually it can expand into that area over the inguinal ligament. Okay, pushing the fascia lata with the content here, which can confuse a femoral hernia with inguinal hernia. Okay. Okay, so these are the other points that about femoral hernias. You know about it better than me. I think it's common in females because they have a wider pelvis than femoral canal. Okay, lies deep to deep fascia and these points. Okay. Then about the inguinal lymph nodes. Inguinal lymph nodes is initially divided into two groups: the vertical group and the horizontal group. Vertical group lies along the great saphenous vein. So that's done. Then the horizontal group is divided into two halves, a lateral half and a medial half. Now the medial group of horizontal nodes, superficial horizontal nodes, is more important than the lateral group because the lateral group, we'll come back to the drainage area later. Okay. Then when it comes to the deep inguinal nodes, deep ones, they lie medial to the femoral vein in the femoral triangle, and the upper nodes, few nodes, they enter the femoral canal. Okay, femoral canal, and these nodes which enter the femoral canal, they are called nodes of Cloquet. I'll show you. Okay, and all inguinal lymph, whether it's superficial or deep, superficial deep usually drains into deep nodes. Most of the superficial lymph drains into deep lymph nodes, and whether they enter it or not, ultimately both will drain into the external iliac nodes. Okay, external iliac nodes. Then when it comes to the areas drained by the inguinal nodes, now deep lymph nodes, they drain the superficial lymph and the deep parts of the they drain the superficial lymph nodes as well as the deep parts of the lower limb and the popliteal nodes. and the glands pleenis and clitoris in females. When it comes to vertical group of superficial inguinal nodes, the whole superficial lymph, whole of the superficial lymph of the lower limb is drained by the vertical group except for the lymph from the posterolateral aspect of the leg, drained by the lymphatics accompanying the small saphenous vein and drained into popliteal nodes. Other areas all are drained into the vertical group of superficial inguinal nodes. Then when it comes to horizontal group, which is more important, lateral one drains the buttocks and the flank and the back below the waist. So it's not very important. But when it comes to medial group, which is an important group, horizontal group, it drains the anterior abdominal wall. If this is your anterior abdominal wall, below the umbilicus, the superficial lymph below the umbilicus drains into the medial group, as well as lymph from the perineum. So in males, the skin from the shaft of the penis, skin of the scrotum, and the lower part of the anal canal, and in females, lower part of the vagina, they all drain into the medial group of superficial inguinal nodes. Then when it comes to the uterus, in females, this is called the cornu of the uterus. Round ligament is attached to the cornu of the uterus. So lymph from the cornu of the uterus, the cornu of the uterus, can drain through the round ligament into the medial group of superficial inguinal nodes when the round ligament is attached to the labium majus in females. Okay. So for that reason, medial group is important. Then, as I said before, all inguinal lymph ultimately drain into external iliac, then from there into common iliac, then from there into para-aortic nodes. From the para-aortic nodes, they enter into cisterna chyli, and through the thoracic duct, they enter the circulation back in the neck, root of the neck. Few things about femoral triangle. Its base is the inguinal ligament, and the lateral border is the medial border of the sartorius muscle. Lateral border is the medial border of the sartorius muscle, and the medial border is the medial border of the adductor longus muscle. Because of this definition, adductor longus actually forms the medial part of the femoral triangle. Some authors take this border as the medial border, but I recommend you to take the green line that I showed you here. Okay, so that it is included. It is included in the femoral triangle, forming the flow. Adductor longus forms the flow because of this reason. Okay. So then the muscles that form the flow of the femoral triangle, you can see adductor longus here contributing to form the flow, then the pectineus muscle. Then here, this femoral vein actually lies on the pectineus muscle. Then this is the femoral artery, it lies on the tendon of the psoas. This is the femoral nerve. Look at the arrow. Okay, my pen is not working. Okay. Now this femoral nerve, it lies on the iliacus muscle. Okay, so these are the muscles that form the flow, and these become the contents. Okay, femoral nerve, vein, artery, they are contents of the femoral triangle. And at the apex of the femoral triangle, the adductor canal starts. Adductor canal starts here. Adductor canal is also called subsartorial canal because it lies under the sartorius muscle, or it is sometimes called Hunter's canal. Okay, and it is in a groove between the vastus medialis and adductor muscles, and the roof is formed by the sartorius and fascia under the sartorius. So it's like this. So you get vastus medialis here. These are adductor muscles. So this is the groove between the two groups of muscles, and the roof is formed by the sartorius and fascia under it, and it contains the femoral artery, the femoral vein. Then you have the saphenous nerve throughout. Then you have in the upper end, you have the nerve to vastus medialis, upper part, the lower part you have to take as the posterior division of the obturator nerve entering it. Okay. Few points about the femoral artery. As I said before in one of the previous slides, it enters the thigh at the mid-inguinal point here. Mid-inguinal point is the midpoint between the anterior superior iliac spine and the symphysis pubis here. That is mid-inguinal point. Now the midpoint of the inguinal ligament is further lateral to it. Okay, midpoint of the inguinal ligament is somewhere there, because that is between the pubic tubercle and the anterior superior iliac spine. So that's a different issue. So this is the mid-inguinal point where you can feel actually femoral pulse against the psoas tendon lying in front of the hip joint. Then yes, you can feel femoral pulse, and for arterial catheterization you can use this site or to draw blood, I think, with catheterization for blood gas analysis or something. I might get wrong in some of these things. You know this better than me. You are in the clinical setup now. Then this is the point that I wanted to raise. It lies over the psoas tendon, and the psoas tendon actually separates the femoral artery from the joint capsule. Okay, so you have the artery, you have the psoas tendon, and you have the capsule of the hip joint underneath that. Okay, so that is the point. And the four small branches that I will not mention, you have superficial circumflex iliac, superficial epigastric, and superficial and deep external pudendal. Okay, so those are the first few branches given from the femoral artery before the profunda femoris artery is given. Okay, and remember the point that and the profunda femoris, when it is given, it is given off distal to the, now if the femoral sheath is here, profunda femoris, this is too distal, I think. Okay, it is given just lateral, just distal to the femoral sheath, profunda femoris artery. Okay, not within the femoral sheath usually. And the profunda femoris artery, it can be called deep femoral artery. Okay, it is called deep artery of the thigh as well, deep artery of the thigh or deep femoral artery. And when it is called deep femoral artery, the femoral artery proper can be called superficial femoral artery. So radiologists, use these terms very frequently: superficial femoral and deep femoral. I don't know about the surgeons and others. I have heard radiologists using it very frequently. Not this, the terms that anatomists use very much: superficial femoral artery and deep femoral artery. Okay, so deep femoral artery, in that case, this one is a branch of the femoral artery. In other words, femoral artery divides into deep femoral and superficial femoral artery, which is, better. So this deep femoral artery or profunda femoris artery, it actually passes between the pectineus. Once it is given off from the femoral artery, passes between the pectineus and the adductor longus muscles. And it lies behind the adductor longus muscle here. This is the posterior view. It lies behind the adductor longus muscle, and the superficial femoral artery lies in front of the adductor longus muscle. So the muscle is sandwiched between the two vessels, deep and superficial femoral arteries. And the other point is, now this is the medial side, this is the lateral side. Now the deep femoral artery it lies lateral to the superficial femoral artery. Now this is the superficial femoral artery, this is the deep femoral artery. It lies on the lateral side, more closer to the femur, The deep one is more closer to the femur. And there are three types of branches given by the deep femoral artery. You get, I think the branches are given, yeah. You get lateral circumflex femoral artery, which is given from the lateral side of the profunda femoris artery, the lateral side. Then the medial circumflex femoral artery given from the medial side of the profunda femoris artery or the deep artery. And then you have several perforating arteries given from the posterior aspect of the profunda femoris artery. Okay, So it's more than 3 branches actually, but it's 3 types. Okay, 1, 2, 3 types. So this is the point that I wanted to raise. The deep artery lies lateral. Now this is the lateral side, lateral to the superficial femoral artery. So in fact it lies more close to the femur, or you can say it lies, I'm referring to the deep one, lies between the superficial femoral artery and the femur. Okay, in different ways you can express it. So it becomes important actually in an arteriogram like this. In an arteriogram, sometimes if there is a block here, this can be less prominent, this can be more prominent. Okay, so don't get confused between the superficial and deep femoral arteries. Go by the relative position to the femur, lateral medial business. Then ligaments of the hip joint. There are several ligaments. 3 main ligaments are there. Iliofemoral ligament, which is the main ligament, the strongest one of all. It is an inverted Y-shaped ligament. The base is attached to the anterior inferior iliac spine. Base is attached to the anterior inferior iliac spine here. And the 2 limbs of the Y is attached to the intertrochanteric line. And it prevents overextension. All these ligaments, they prevent overextension actually. Then the second ligament is pubofemoral ligament. It is a triangular shaped ligament, base attached to the superior pubic ramus, and the apex again attached to the intertrochanteric line. Again, it prevents overextension, it limits extension and abduction. Then the ischiofemoral ligament, the third one, which is an oblique ligament, rises from the body of the ischium here, and the ischial tuberosity to some extent, and then it limits again extension. Okay. Then you have the transverse acetabular ligament, which is this one. Then you have the ligamentum teres. You have the ligamentum teres, or the ligament of the head of the femur, which is attached to the head of the femur here. So relations of the hip joint. I mentioned a few things about the relations of the hip joint. So the first point that I mentioned, you get the pectineus muscle here, you get the underneath this femoral artery you get the psoas, and underneath the femoral vein you get the iliacus. So these 3 muscles actually lie immediately in front of the joint capsule there, and separating the capsule from the femoral nerve, artery and the vein. Okay, the 3 muscles, pectineus, the psoas and the iliacus. Okay. Then there is a bursa sometimes separating the iliopsoas from the capsule. Then other relations of the hip joint here. This is a coronal section of the hip joint. In this section you can see superior to the joint capsule lies the rectus femoris. Now this is rectus femoris muscle, and this is gluteus minimus. This one is gluteus minimus, this is rectus femoris. Okay, so the one is medial, other one is lateral, further above and medial, above and lateral. Then inferiorly lies the obturator externus muscle. Posteriorly lies the piriformis here, you can identify piriformis here. Then you get the gamelli muscles and the obturator internus muscles. Obturator internus muscle, superior and inferior gamelli muscles. Then the sciatic nerve here, this is the sciatic nerve, is separated from the joint capsule by the gamelli muscles, inferior gamelli in this case. Then laterally the capsule blends with the iliotibial tract, so that's clear. And medially, it's important, medially the acetabular fossa, now you have the acetabular fossa like this, it forms the lateral wall of the pelvis, so that is that area. lateral wall of the pelvis in that area. And the important point here is deep to the acetabulum there, you get the lateral wall of the pelvis, and the ovary, it happens to be the ovarian bed. Ovary lies in that area, and between the acetabular fossa and the ovary lie these obturator nerve and vessels. Obturator nerve and vessels. Now, if you get acetabular fractures where the head of the femur is driven into the pelvic cavity, these structures can get damaged. Okay, these important structures can get damaged. You can get heavy bleeding into the pelvic cavity as well. Okay, try this one. Profunda femoris artery lies lateral to the femoral artery. Yes, it is the first branch of the femoral artery. Wrong, because there are other small branches before it is given off. Is given off inside the femoral sheath. Usually it's given distal to the femoral sheath. Okay, gives off 3 branches. It's more than 3 branches. Okay, I said 3 types of branches. So it's more than 3 branches because there are several perforating arteries. Then passes deep between the adductor brevis and longus. No, it's actually, it enters. It's a little bit, vague when it says passes deep between. The moment it is given off from the femoral artery, it goes deep, and when it goes deep between the pectineus muscle and the adductor longus muscle. Okay, and lies behind the adductor longus muscle. It's a little bit, tricky. Try this one. These are straightforward things. Medial group of superficial inguinal nodes drain the uterus. Yes, it drains the conum of the uterus through the round ligament. Vertical group of superficial inguinal nodes drain the dorsum of the foot. Yes, superficial inguinal nodes, they drain all superficial lymph except from the posterolateral aspect of the leg. Okay, so the dorsum is included. Deep nodes in the femoral canal drain glans penis. Yes, glans penis, and in females clitoris, and the same nodes. Okay, deep nodes in the femoral canal, they are called nodes of Cloquet. Okay, drain the skin of the penis. Wrong. Drain the skin of the penis drained into medial group of horizontal group of superficial inguinal nodes. All inguinal nodes finally drain into external iliac nodes. Okay, not internal iliac. Contents of the adductor canal include this we have discussed several times. It includes the nerve vastus medialis, great saphenous vein is in the superficial fascia. Profunda femoris artery passes behind the adductor longus muscle, so it's not inside the canal. Superficial femoral artery is the femoral artery, actually, it's true. Then the obturator nerve, actually, you can mark it true, but if you say anterior division, it's wrong. Posterior division, it's true. It's a very short distance, it can be there in the adductor canal. Okay, I used to mark it wrong, but then students argued that it has to be there, and certain textbooks say that it is a content of the adductor canal at the end. Okay, so you have to mark it correct if it is the posterior division. Okay, then other femoral vein and then the saphenous nerve, there are other contents. Collateral circulation of the femoral artery. Now it's important to remember the collateral circulations, especially in case of gradual occlusion of the main artery. Now, if the gradual occlusion of the femoral artery is proximal to the point where the deep artery of the thigh is given, that's what is meant by proximal. Say, it's obstructed inside the femoral sheath, something like that. Okay, it's a proximal obstruction. Then what happens is you get these 2 anastomoses, cruciate and trochanteric anastomoses. It's like this. You get the femoral artery like this. You get the profunda femoris artery, and from that you get the medial and lateral circumflex arteries and perforating arteries. Then from the internal iliac artery, you get the superior and inferior gluteal arteries. So these unite and the anastomose and form the cruciate and trochanteric anastomoses. So if you block the femoral artery proximally, blood will flow from the internal iliac through the superior and inferior gluteal vessels in these trochanteric and cruciate anastomoses, and blood will enter into the deep femoral artery. From the deep femoral artery, they can now enter the superficial femoral artery, and the blood supply can continue from there onwards if the obstruction is gradual. Okay. Now, if there is a distal obstruction, on the other hand, if there is a distal obstruction, in the sense obstruction is distal to the profunda femoris artery, now then the blood will actually come from the femoral artery, enter through the deep femoral artery, and these perforating arteries anastomose with the muscular and articular branches of the superficial femoral artery distally, and blood can go backwards like this. Okay, someone has typed something. So, can we take profunda femoris artery as a content of the femoral? It depends, because it is given off in the femoral triangle, and then only it enters. Technically it has to be taken as a content of the femoral triangle. If someone specifically asks it, you cannot mark it wrong, even though we don't discuss it all the time. If somebody say MCQ or somewhere, if they put it as a content, you can't say it's wrong. Okay, it's like in the cubital fossa, even though we conventionally don't mention, we took even these recurrent arteries of elbow anastomosis as parts of the cubital fossa, because they are given off in the cubital fossa. It's like that. Okay, if somebody asks, then you have to rethink. Okay, you will have to. I will mark it correct. Okay. So this is the point. So if the obstruction is distal, actually, then blood will come through the then you don't have to get blood from the internal iliac. Blood will come like this, goes through the deep artery, and then the connection, the muscular branches and branches to joints have anastomosis. Through these branches, blood can flow back into the superficial femoral artery. Okay. Then about the two anastomoses that we mentioned, trochanteric and cruciate anastomoses. The trochanteric anastomosis, it is near the trochanteric fossa, that area. Okay. And the anastomosis is between the descending branches of the superior gluteal here and ascending branches of the inferior gluteal and lateral and medial circumflex arteries, lateral and medial circumflex femoral arteries. Then when it comes to cruciate anastomosis, it's the inferior gluteal that is involved. Inferior gluteal nerve, the inferior gluteal nerve and the branches of the medial and lateral circumflex arteries again, and the first perforating artery also contributes to the cruciate anastomosis. There are ascending branches from the first perforating artery. So these are the two anastomoses which is around the lesser trochanter. So this anastomosis is around the lesser trochanter area. The other one is around the trochanteric fossa area. Now when it comes to, we'll discuss anyway, when it comes to the blood supply of the head of the femur, this trochanteric anastomosis become more important than the cruciate anastomosis, remember that. And of the trochanteric anastomosis also, even though there are several vessels involved, of the trochanteric anastomosis, medial circumflex femoral is the most important single. If somebody asks for a single artery that is most important in trochanteric anastomosis, it is the medial circumflex femoral. Okay, if you have to compare between the cruciate and trochanteric anastomosis, trochanteric one is more important than cruciate, even though they are all connected up. Okay. Okay, so this is the point. But blood supply of the head of the femur. I think these are common topics that you also study in undergraduate things. You know these things. I will just remind you certain things. Now, when it comes to the attachment of the joint capsule, you know that you have the acetabulum here. So one end of the capsule is attached to the acetabulum here. Then the other end is attached to the edge of the articular cartilage. Okay, articular line there. So this capsule on the anterior side, the capsule is attached to the intertrochanteric line. Okay, so if I draw it here also, posteriorly it is attached, it is not attached to the intertrochanteric crest, okay, not attached here, it is attached halfway between the this line and the intertrochanteric crest, so it's attached to the neck. This is on the posterior side. So wherever it is attached, the fibers from this end, the fibers of the capsule are reflected back along the head of the femur, and these are called retinacular fibers, and they end here. Attachment ends there. So when they go there, the not here, the synovial membrane that is immediately under the joint capsule, it also goes with these fibers, okay, and that is one point that you need to remember. Then the blood vessels that are originating from the trochanteric anastomosis, they run in between these fibers, retinacular fibers. Therefore, these vessels are called retinacular vessels, okay, retinacular vessels. And since the synovial membrane is there, okay, over the retinacular fibers, sometimes these arteries, retinacular arteries, are said to be subsynovial, okay, because the capsule fibers are there, the synovial membrane is inside, arteries are between these, in between, like, okay, so it's this is synovial membrane, so it's subsynovial. So the issue here is, so in adults, this is the main supply to the head of the femur. In children, you get in children, in the sense, before the epiphyseal plate is closed, you have an epiphyseal plate here. Before the epiphyseal plate is closed, actually closed in the sense, you know, you have the epiphyseal plate there. So then, you know, there's another supply from a branch from the obturator artery through the ligamentum teres. It supplies the head. So in children, this supply is important, this supply. Therefore, even though they fracture their neck of the femur, avascular necrosis might not happen. But in adults, once the epiphyseal plate is not there, closure of the epiphyseal plate, then issue is this blood supply becomes less and less reduced, and this supply becomes the main supply. So when they get a fracture here, then the blood supply is cut off to the head of the femur, you get avascular necrosis. And for this to happen, actually, if you say fracture here through the intertrochanteric crest or something, some of these blood vessels are left. You may damage some of these anterior ones, but the posterior ones are left behind. So you might not give rise to avascular necrosis. On the other hand, if you fracture an intracapsular fracture of the neck, then you will get avascular necrosis. Okay. So these are the two sources of blood supply. In children, you get the arterial supply from the obturator artery through the ligamentum teres, and then you get, in adults, you get main supply from through the neck here, through the two anastomoses, as well as you get nutrient arteries and all entering this and going into that area. Okay. So your retinacular vessels actually lie here, deep to the synovial membrane. That's why you call them subcapsular. Okay. Okay, so this I mentioned, obturator artery, trochanteric anastomosis. So this is the point that I mentioned, main source of blood supply to the head of the femur, trochanteric anastomosis, and the medial circumflex artery is more important than other arteries. Okay. Okay, so if you get a fracture here, subcapital fracture, transcervical fracture, these ones are more likely to give rise to avascular necrosis than other fractures. Even this one, will not affect the posterior fibers very much. Okay. Okay, try this one. It's a straightforward question again. Okay. So obturator nerve supplies obturator externus, not internus. Sartorius is supplied by the femoral nerve. Adductor magnus, yes, the adductor component of the adductor magnus. Hip joint is supplied by the obturator nerve. Knee joint. Hip joint is supplied by the anterior division, I think. Knee joint is supplied by the posterior division. Again, obturator nerve. Some of these things are not related to the lower limb directly. It carries L2, 3, 4 segments, yes. It pierces medial border of psoas major muscle. Now this is in the posterior abdominal wall. Okay, so if you remember the lumbar plexus, you get, if this is the psoas major muscle, you get certain nerves arising lateral to it. Then the femoral nerve lies in front of it. Obturator nerve pierces the medial border of the psoas major. So because of that, it is true. Then it lies medial to the sacroiliac joint. Yes, this is when it enters the, if you get the sacrum here like this, and you get the, it passes like this. Once it enters the comes out from the medial border of the psoas major, it passes. It lies medial to the sacroiliac joint at the pelvic rim. Posterior division supplies the pectineus muscle. It's the anterior division that supplies. Then it crosses the ovarian fossa. Yes, it crosses the ovarian fossa, and it actually lies between the ovary and the acetobulum, lying laterally. I told about this before.